Good afternoon and welcome back, everyone. Thank you again so much for joining us here at the HitLab Innovators Summit. It is my great pleasure to introduce the next panel discussion, the rise of virtualization of care. In recent years, we have seen a massive acceleration in the use of digital health platforms as hospitals and health systems are exploring a variety of virtual care models. Implementation of digital health care enables a model of care that is ubiquitous and seamless, more affordable, and integrated into patients' lives. In the shift to demand-driven healthcare, digital health platforms become the patient's first and most frequent point of access for urgent care, triage of emergent conditions, specialty consults, post-discharge management, medication education, behavioral health counseling, and chronic care management. Enter our panel. Please join me in welcoming our panel who will be talking about the rise of virtualization of care. Allow me to introduce my personal mentor and the chair at HitLab, Dr. Stan Kachnowski, who is also the director of the Digital Health Strategy Program, Executive Education at Columbia Business School. Also joining us is Dr. Paul Testa, Chief Medical Information Officer at NYU Langone Health. Dr. Claus Jensen, Chief Technology Officer at Memorial Sloan Kettering Cancer Center, and Vinod Parale, President at Persistent Systems. Thank you all so much for joining us today.
Yeah, thank you, Justin. And again, thank you to these very busy executives that are in the midst of doing a lot. Again, I think there's how many days left in the business year, like 10 or something. I mean, we're winding down 2020, and I think most of us are glad to put it behind us. And certainly, the three of you are very busy doing a lot of different things, responding to the pandemic with digital solutions. And we appreciate your time today to do this and to share, again, to be open to sharing some of your learnings about how to virtualize healthcare systems. This is not something people are often generous enough to do. You saw Glenn and Lee from Livongo before you. Again, extraordinary individuals and tremendously generous with their time to help share learnings and be open source about their knowledge. I wanted to kick things off with just a quick couple of minutes from each of you about your background, your journey, really, like what got you into digital health. It's not something like telecom or finance or retail. Neither of my kids ever asked me and said, "Dad, how do I get into health IT and digital health?" Neither of them. Like, what? This is not cool. Now it's starting to be cool. Apple Watches, electronic health record systems, and personal health records, getting data, understanding the supply chain. We talked with one of the supply chain executives from Merck this morning, and now all of a sudden, my kids are asking me, "So how does this work? And what does this do? And how does this data work here?" And now we have all kinds of interesting, cool factor things happening within the digital health ecosystem. And so hearing about your journeys and how you got into it would be a wonderful way to start the conversation. And Paul, why don't you start? And then obviously Klaus and Vinod.
Thanks, Dan. So by way of background, I was an emergency medicine attending at NYU Langone. I did my residency training here. And about 2 weeks after my residency, my chairman said, newly minted attending Testa, go to an order set meeting to validate our order sets. I turned to him and asked him what an order set was, and he says, "I don't know, go find out." And it took about 10 minutes to realize this was going to change the world for us. That was about 10 years ago. And what I was told by an old ED nurse who was turned informaticist is, when you validate this order set, this is how you will treat pneumonia across the entire health system. And that's all I needed to hear. Think about, you could perturb a system in that way. And then as I sort of committed to informatics, they were looking for change agents. And they said, "You work in the ED, everybody doesn't really hate you. So why don't you be the face of how we change and move digital health into the health system?" And that's sort of what stuck. And then I stayed. I got into it for that reason. I stayed because I'm at an institution that looks at the use of digital health as a strategic advantage for our patients and our providers. Thanks, Tim.
Yeah, and now it's interesting, right, Paul? I mean, it's not even a strategic advantage anymore. Now it's a financial imperative. I mean, we've gone from being the kind of like out of Office Space. I don't know if you guys ever saw that movie, but kind of being the guys in the basement with the red stapler, to now being called into the CFO's office every day to understand what is actually happening with the revenues and how can, electronic health record systems and telemedicine and remote patient monitoring somehow or another somehow save and scavenge whatever money we can for reimbursements in this virtual healthcare system, and that's what we're here to talk about today. And again, you know, Claus, if you could go into a little bit more detail about your background. You're obviously not from Brooklyn, and
I'm not from Brooklyn. That's right.
I don't detect that sounds like it could be a Boston accent, but I'm not thinking it's Boston accent either.
No, it's not. I'm born and raised in Denmark, so I've had a long journey to get to where I am today. I actually started out in the bank, which is another regulated industry, and I learned all kinds of stuff around financials. That's been kind of interesting these days because, as you said, we have to marry the financial understanding of what's happening with this emerging notion of virtual health. Then I got into technology. I spent 7 years working for technology companies. I sort of got inundated in what does it mean to be on the vendor side. And what I found along my journey as a professional is what gets me up in the morning is to leave behind a better team, a better institution, and preferably a better world. So when I got the opportunity to go be the CTO for Aetna, which is a healthcare organization, it's one that's not just a big bad insurance company that actually care about the people that are on their plans, that they said, yeah, I want to go do that. It was also a way of replying to the 12 physicians and 3 nurses in my family that have asked me ever since I took my doctorate in computer science, when are you going to do something useful? So getting into healthcare was a little more useful than working for a technology company. And then a year and change ago, I got the opportunity to be the Chief Digital and Technology Officer for Memorial Sloan Kettering. Cancer is a fascinating disease. It's scary. There's too much of it, yet it's very difficult to address because it's so complicated. And what I do here is actually answering the question you started out with. If the problem we're trying to solve isn't how to help people in a hospital when they have become sick, but how to help them stay healthy wherever they are, what does that mean for what a provider looks like? And the answer can't be only people and facilities, because that doesn't solve the problem. So we're in this fascinating hybrid world where the very nature of the problem changed, perhaps more fundamentally than it has in more than 100 years. And ever since we got out of the whole business with village doctors and became specialized, I think this is as profound a change as that.
Yeah, I love that. I think, you know, I think how many times have we heard the words inflection point, revolution, used by analysts and Wall Street, you know, people and industry people. And, you know, I'm sure that the 3 of you being in the front lines, being practitioners, you hear those terms usually in the last 30 years, even during the .com revolution. You know, there were a lot of websites, they weren't making a lot of money in the 90s. And when people lost a lot of money in March of 2000, when the stock market dumped about 50 to 60% of its value out. And WebMD, for instance, went from like $75 to $3 a share. So I think today, and certainly disagree with me, please, I love debate, but we can use the words inflection point and revolution as not a 40-year industrial revolution, but a 10-month, 8-month digital revolution in healthcare. We've seen not just telemedicine go up in places like NYU and Memorial Sloan Kettering, but we've seen the adoption rate and the activity rate go up substantially. It didn't come down a little bit and then go back up now, but you know, it's extraordinary. It is really a different time. Thank you for making that point. And Vinod, again, really good to have you on board. Thank you as someone who's not just working with one institution, but as a president of a global leader in healthcare solutions and really providing a lot of these hospital systems, these health plans, these life science companies with the technical solutions, the tactical details needed to be successful, resurrect and save whatever revenue they can. Let's hear a little bit about your journey and how you got to healthcare, specifically in digital health.
Yeah, thanks, Stan. So I'm technologist for like last 20 years, and around I think 10 years back, you know, I was helping one of the banks to execute some project just like Claus. And then I was brought into this project where we were helping one of the wound care company. They provide wound care services to different health systems, and they were struggling with, you know, because they were deployed in some 400 different health systems. They were kind of battling with very interesting problem of connecting to almost 300 plus EMRs, right? And they would duplicate a lot of their tasks, and you know, instead of focusing on patient and care, their care team had to focus on, all these technology challenges. So I was brought in to, run that project. And like, that was my first encounter with healthcare around 10 years back. And I was like awestruck with kind of, things that are going on with healthcare, and, what kind of impact technology make. I was kind of, introduced to that problem last 10 years back. And since then, I'm working and helping health systems and, providers and pharma companies and peer on same journey to take care of the patient and keeping patient at the center and using different digital technologies to, do their job. So that has been like, little journey, Stan.
That's a great journey. It's interesting, just the two of the national leaders in digital health coming from Denmark and from the subcontinent in India, and it's great to see. And certainly one of the things that I've seen in my teaching career at IIT New Delhi has been just this influx of people, of students, and it's all graduate students that I teach there. And over the last 15 years that I've been affiliated with that department, the rise of interest in healthcare. Again, when I started out there, my classes had maybe 9 or 10 students. Healthcare wasn't cool. It was all finance and telecom and the cool concentrations. And now they're packed. So it's a much different story now than it was 20 years ago. Healthcare has become, and certainly biomedical informatics and bioinformatics and in digital health, it become very, very avant-garde and much cooler now than they've ever had before. And let's talk about the virtualization of care. I think Dr. Testa, from your standpoint, what have been some of the critical points that you've seen that are needed for hospital systems to rapidly and with agile techniques and using technologies to deploy them, that you've seen and you've actually gone through at NYU to adjust to the pandemic and virtual care?
And I love that you called out inflection point, because it seems to be the bingo word of this year's pivot. And what I keep responding to is none of this has been a pivot. I think the steps were taken 4 years ago in laying out foundational tools that can scale. So what we chose to do when we started on our telehealth, our virtual health pathway, now 3+ years ago, was to deeply integrate it into our EHR and not put together 4 or 5 different tools. What we found is, because we leveraged something like Epic, because we leveraged a single video client and heavily relied on patients' mobile devices, which are so pervasive now, we were able to scale in the space of about 10 days from 25 video visits a day to 8,000 video visits a day. That is not just the technology. That has a lot to do with the operational infrastructure from the faculty group practice and from the hospitals. Likewise, it was a recognition, for example, when we built a new pavilion, that let's sneak telehealth into the background, and one day we're going to need it. So 18 months ago, when we opened up that pavilion, we had 5,000 telemedicine endpoints. We had no idea what we were going to do with them. But the idea was installed at that point, again, at a platform level, and then leverage the tools quickly. And that's not a pivot. That's just ramping up, escalating. I think that was really an important part of this process, and to look at both the patient aspect and the provider clinician aspect, which allowed us to do things like minimize nurse entry into rooms and save PPE and patient exposure.
Did we lose Stan? He looks frozen.
I think he's frozen.
That's all right.
Maybe
why don't I answer the same question? So I agree with everything that Dr. Testa said. That was very well put. So I'll take on from where you left off and continue to say, when you look at the spectrum of primary care, secondary care, and tertiary care, and we're at tertiary cancer center, it turns out there are actually fundamental differences. The primary care, while it's a journey, it's a relationship. It has a more, acute is not the right word, but a more discrete nature in terms of the fact that I have a condition, I need to do something with it. And a lot of that is I need to see someone that can help me. And it's not necessarily important that it is always the same person as I saw last time. In particular, when you're looking at different specialties, it could be different people. When you go to the tertiary cancer centers, certainly, right? Cancer is in many cases a multi-year disease. It's a disease that's very complex. You're wrapping a care team around it. There is a primary oncologist. There might be a clinical trial nurse. You have the practice nurse. You have the nutritionist. You have the psychologist. So there's a whole care team wrapped around the disease. And when you start trying to do that kind of integrated care, some of the technologies that are out there come up short. So we had actually done all the preparatory work. We'd put in a platform.
What's up?
And we had started working on what does that look like.
Frozen now?
Now we can hear you. And we weren't unprepared. And we did the same that you did, which is we scaled from 2% of our visits to all of a sudden 2 weeks later it was 60% of the visits. So it was like crazy. We multiplied by a factor of 20. But we also have to realize that was telemedicine version 1.0. And what we're now looking at is telemedicine version 2.0, because the audio video connection, the ability to put two people together, like, that's fabulous in this little live stream. That's the easy part. The hard part is how you wrap a whole care team around it and make sure that you've got all the right things scheduled. How you figure out that you've done all the tests before you get to the actual visits so that you don't end up with a visit and we can't do it because we didn't do the tests. That you've gotten the records so that you can have the right conversation if this is a referral from somebody else, or again, it doesn't make any sense. That you do the teledisposition, that you know what the follow-up tests are, that you do all the follow-up scheduling, which is now wrapping into the non-clinical part of the care team. That's the hard part. And doing that across a complex care team on the MSK side, and also complex team on the patient side, which is the patient, it's their family, it's the caregivers. We know that cancer patients in many cases don't remember what we talked about because it's scary. And you just don't remember it. So you got friends and family and caregivers that come with you so they can help you remember what happened and be part of the support apparatus. That model, that's what I would call telemedicine 2.0, where it's now an integral part of an integrated care model, much harder. And we're building a whole new generation of tools on top of the audio video connection, but that alone won't actually solve the problem. So redefining the problem from televisit, you use the word telehealth, I like that, or you can say telemedicine. It's a much bigger problem than the televisit. The televisit, that's the easy part.
Yeah, and apologize for the technical difficulties, guys. Someone in my household, it was probably just downloading a video on Netflix or something. I have no idea what just happened, but anyway, appreciate the carrying on. And I think that, it does what you're saying, Dr. Jensen, is really synchronized with what Dr. Testa is talking about in terms of this. It's not about necessarily new things. It's about scaling up what's already been in place and maybe optimizing it now, because instead of, maybe a couple of hundred physicians using telemedicine on a regular basis, now it's everybody. And it's trying to find ways to keep patient beds and ICU beds empty, or control the flow of those by having folks do more remote patient monitoring, do more things at home. I just saw the stat yesterday, was stunning. We have about 100,000 ICU beds in this country. About 5,000 are burn, about 18,000 are peds and NICU. All of those beds have been used. We're at capacity as a nation right now for ICU beds, which is stunning. It's just never happened before in the history of the United States. And so this is why the virtualization of care is so critical. And we had, and that's really critical. You were going to say something, Dr. Jensen. What were you going to say?
No, I was just going to add on top of your optimization point, which is, here's a data point for you. Right? Our oncologists with telemedicine 1.0 generation tools can generally see only about 2/3 of the patients that they can see in a clinic. Because the way the technology works, they are too much of the coordination point for the entire visit rather than the flow across different roles that you normally see when you're in physical clinic. So we absolutely have to solve that. ICU beds is one thing. There's the very clinical staff resources we have, and then you tied it into the at-home monitoring. We increasingly need to take care of people, not just in facilities, not just in outpatient care, but at home, and be comfortable with not having them admitted in a scenario where, yeah, they do need monitoring. They just need the monitoring at home.
Fantastic. And Vinod, maybe you could continue as well and carry on a little bit. Tell us a little bit more about what you're seeing in the virtualization movement, if you will, and how the scale up is affecting some of your clients and client base.
Yeah, so across the board, we are seeing, I agree with Dr. Jensen's observation, so video visit is just the first part, right? And then second, and now a lot of health system and providers kind of making progress towards, monitoring and providing care where patient is at, and, really using, technology, data, to continuously monitor trajectory, and then complex conditions like oncology and other disease conditions would really be helpful for patient as well as provider to use this technology for continuous monitoring. So I wholeheartedly agree with Dr. Jensen. So it is not just video visit. Video visit is like first step. Now some of the providers are going further, and they're utilizing data, algorithm, machine learning, and other technologies to really monitor these patients on continuous basis. And then they are kind of looking at some of the very interesting business outcomes and growth opportunities by using technology and data as a tool. Some of them are like, how do you want to deploy your most precious resources, like providers and care team for right patient, and that kind of decision is kind of becoming easier to make with technology deployed, and virtual care and platforms and other elements that Dr. Jensen was also talking about. So I think we are not going to stop here, right? This is just a first milestone in the longer journey, and it is going to get better from patient and provider perspective in my view.
Yeah, this is an amazing story. We're getting lots of great comments on the feed, and really appreciative on that. Let's talk a little bit about remote patient monitoring, Dr. Testa, and what you're seeing there. We were talking to a distinguished panel very early in the morning yesterday to reach our audience in the Eastern Hemisphere, and we were talking about the use of remote patient monitoring we had the head of the Telemedicine Society in India, we had the head of HIMSS India, and then we had the chief digital officer from the Gates Foundation India, and a lot of it was around infrastructure support, financing support, and we've seen this, right? We've seen this here as well. It's not just the technology, it's not just the training to get everyone to understand how to use the technology, but then it's also the reimbursement patterns. And that's what really cooked a lot of hospitals. And we've seen, rampant bankruptcies here in the US over the last 10 months. And so when you look at remote patient monitoring, Dr. Testa, how has that affected the virtualization of care? Have you seen that scale up, and how or why not in terms of working and actually, covering those three areas of technology usage, training, and then reimbursement?
That's of late, in the last maybe 4 to 5 months, it seems like RPM, remote patient monitoring, is always the coda that gets added. That's our next great step. And I think what we were forced to face with the onslaught of COVID-19 in New York City and now in the country, as quickly as we rose to video, right? That's the 1.0. But Claus nails it. The 2, maybe 3.0 is going to be the coordination of patient data and moving our patients off living their lives on small pieces of paper, which is what we have asked them to do for far too long, and we don't know what to do with that paper any longer. So as we've moved patients from the inpatient setting to an ambulatory management to frankly caring for themselves in an integrated fashion at home, again, Claus, you call it out correctly, like a quaternary cancer center, you have to, it's so much coordination. So where we're going to need to succeed is not putting the provider at the center of it, but rather having the patient's information hitting us in a coordinated fashion in a way that continues to add the value proposition of video as a complement to in-person encounters. Right? So we proved ourselves that we can provide good, highest quality care via video to thousands, hundreds of thousands of individuals. But now how do we integrate that with a mixed model of in-person care and ambulatory remote care? Reimbursement has to accelerate around that. There's no two ways about it, although there has been changes the changes that came down were pre-COVID around that, and those restrictions will continue to fall. And then it comes down also to patients' abilities and candidly their own tech and health literacy around that. And that's going to be on us to help them with as well. I think that's an obligation that we have to take on as health systems.
Yeah, and I think that's something we're going to cover more about today. We've got one of the leading remote patient monitoring companies now on stage today, I think at 4:35 maybe. And they're actually based in New York City, like both of you. So we've got, it's amazing to see how New York City has become a digital health hub over the last 10 years. WebMD, Metadata, there's a few small companies based here. Certainly having, 3 of the top 25 medical schools between Cornell and NYU and Columbia doesn't hurt that equation. So Dr. Jensen, let's continue talking about that. Very different in a lot of ways, for you guys. Your MSK is focused on cancer and oncology specifically. And when this first hit MSK in March, April, May, I have dozens of former students of mine and colleagues at MSK, and it was stunning to see what was happening to oncology patients and how they needed to survive, and then even the clinical trials, which people don't talk about as much. But if you're running a clinical trial and all of a sudden patients start missing doses, do you throw out the whole study? What do you do with the study stop? And the FDA had to come up with a bunch of dealings and rulings on that. What are you seeing? What are you seeing for RPM and for remote patient monitoring for technologies that are in the home?
It's a fascinating question, and it's fascinating for multitude of reasons. Right, you touched on a few, but let me start with the most basic one, which is many cancer patients are by definition immunocompromised, because that is the nature of the treatment they get. And here you are dealing with a virus in March, nobody understands. But we know it's bad when ordinary people get the virus. And look, it was not pretty in New York City. When you're dealing with a, largely immunocompromised population and a virus that we don't understand, we don't know how to treat it, now what? So you had all kinds of problems. But one part of the problem is we had patients that got the virus and we still had to take care of them. So how do you handle that from a remote monitoring perspective inside the facility? We literally rewired the nursing station so that the calls were remote and that the nurses in many cases didn't have to go into the room. We put, tablets and whatnot in the patient room, so there was an actual connection. You didn't have to don PPE, everything you had to talk. So there was a transformation overnight of the inpatient facility. You had to do something similar in the outpatient scenario where you didn't want people to be in touch more than you had to, not just for our sake. I mean, we can put on protective equipment, but as much for the patients and make them feel safe. And then we had to send people home because we couldn't keep them in the hospital because of all these dynamics. That still had the risk of getting the virus when they were at home. So how do you monitor for that? Right. So we went to pulse oximeters very quickly, because doing basic telemetry on biometrics, you actually get a fair amount of understanding of what does that look like, and it gives you a basic, physician understanding of how do you get there. If you take that to the next level, it's no longer just about how do you monitor someone in a moment. It's about the journey. And we talked earlier about the fact that there's this pivotal, profound moment, whatever we call it, in the history of medicine. If I'd been wearing my badge, it would have said 1884. It's this thing, right? Because MSK was founded in 1884, it's a long time ago. And sometimes I call this an 1884 moment, because the sort of birth of MSK was in 1884. The standard of care was, this is cancer, I don't understand cancer. It's a disease, I don't really know what it does. I can't help you anyway. It might be contagious. I'm not going to get you into my hospital. That's just not going to happen, right? Because that's a bad thing and I can't help you anyway. So go away. That was sort of the standard of care in 1884. And we cringe and say, that can't be the standard of care. Yet for the last 136 years, even the best cancer centers, and it goes for other diseases and other institutions as well, the standard of care has been, when you leave my premises, I can't help you anymore. Look, we can help you inside the hospital, but when you leave here, you're on your own. And it's time to rebel again and refuse to accept that. Because we finally have both the clinical understanding and the technology to build a hybrid care model that begins before disease and ends long after you left the hospital. So in my mind, that's an 1884 moment. And on the provider side, we absolutely have to refuse the constraints that we've lived with for hundreds of years. How's that for an answer?
No, so I think, you know, I love the history of science and the history of medicine infused into this equation, and it really does put it into perspective. You know, these are everyone knows these are unprecedented times for so many different reasons, but you know, this is certainly something to think about even further. And Vinod, we have a question coming in from the audience from Rich, and he's asking about what is the role of the family and the lay caregivers, if you will, the folks that are trained in the basics, but you know, they're not clinicians at all or clinician extenders in the home to utilize these technologies to help virtualize care, but also in trying to reduce costs to the hospital system and improve outcomes. You know, both NYU and MSK are some of the best in the world when it comes to outcomes. And how are these individuals and this population, if you will, more easily engaged by RPM and by virtual care tools than even the patients themselves?
Yeah, so I'll answer part of this question because, you know, we are actively working with, you know, one of the premium institution on similar kind of effort for prostate cancer. So we were able to establish a technology platform that will help this particular, you know, institution to establish virtual clinic for prostate cancer patient. And what we are observing over there, this is just one of the examples. So in this example, what we are observing is, you know, amount of time this patient needs to come back for in the health system has reduced significantly because of, you know, RPM technology we are using there. And then there are like 2-3 components I want to mention here. So how we are kind of helping this particular institution. First part is, you know, obviously data. So you know, we are getting data from EMRs and other you know, clinical systems. The other part is, you know, certain devices that patients are using to you know, report their situations and conditions and how are they feeling and symptoms and so on and so forth. And then third part to this particular setup is basically algorithm that will you know, continuously monitor trajectory of this patient from clinical standpoint. And we kind of partner with some of the clinicians and caregivers from this institution to build out this platform that uses this data, executes this algorithm, and then informs this patient about what are the next steps in the care journey, right? So how this is helping for health system to reduce cost is, you know, basically, again, I'll go back to resource part of it, right? So we don't need to engage specialists for certain visits and certain tasks, you know, patient can do, which are kind of generated by this algorithm of ours for patient to go and take lab test done. And then patient is using mobile device and other kind of devices to report their situation. And that data flows back into our algorithm. And that's how we are continuously monitoring this patient and his patient's trajectory from clinical standpoint. It is immensely helping caregiver to focus on patient, which really needs their attention. And for regular visits and tasks that patient needs to do, that can be done without involvement from specialists. That's where, you know, we are able to kind of help these health systems to reduce cost, right? This is just one of the examples. We have similar example for hypertension, lipid, and few other what we call care pathways, right? So since I've witnessed, you know, more on provider perspective, how it is helping them reduce cost and improve, you know, outcome, that is my perspective. You know, maybe Dr. Testa here or Dr. Jensen can throw some light more on family and other part of the question.
All right, that's great. And I think, you know, all of these technologies now, that was a really great answer, Vinod, in terms of the technology stack, right? It's not just pulse oximeters, it's not just wireless scales. I mean, there are dozens of technologies in various clinical capacities. Some of them have very little clinical efficacy data in terms of, you know, how accurate are they? And some of them are very accurate. And so and some of them are inaccurate, but as long as you use them consistently, then even the inaccurate data is good enough to give us an idea of what's going on from the baseline. And so, yeah, I think great question. Thank you, Rich, for that question. And again, audience, I know we've got several hundred people in the audience right now listening around the world. And if you have questions, just hit the chat box and we'll jump on those questions for these folks. Again, you know, Dr. Testa, when we were having our pre-meet session for this panel, you were called out. You were working on into one of the national vaccine supply chain committees or something. And it would be great to hear from you about how the virtualization of care and what we're seeing within this supply chain. I mean, you know, again, Dr. Jensen talked about historical perspectives here. This is going to be the largest mobilization effort in US history in the distribution of a medical technology. And globally, nothing has approached this since HIV/AIDS or the smallpox inoculation from 55 to 79, when the WHO officially deemed the Earth, the planet, smallpox free, the first and the only disease to be eradicated from the planet. Tell us a little bit about anything. Hopefully you can tell us something about that meeting and about the digitization, the virtualization of what hospitals need to be ready for in order to not only receive the vaccine, but also there's an amazing amount of implementation science in getting a vaccine out to millions of people. Maybe you've got some insight there you can share with the audience.
Wow, I hope I have a lot to learn in this space. The meeting that unfortunately got called away for was, how are we addressing, what's our strategy? How are we going to do this for our 50,000 NYU Langone employees? And there's 7 million patients in our system, 1.5 that regularly engage with us. And what we quickly realized, again, is it's not a pivot. What that meeting was to say that since we committed to moving our occupational health system into our EHR, into all of our other clinical systems, and not have it be some sort of segregated eddy elsewhere, we would be able to integrate both our employee databases with our electronic health record and occupational health tools to use the same tool we would use for a regular patient, that is our phone, to queue up our employees for prioritization and vaccination, and then give them something similar to what we've done with our daily symptom check pass inside the NYU Langone Health app, to give them a tool to say, I've been vaccinated, I've gotten 2, I've completed my cycle, here's my green badge. That partners with them. So lots more to come, lots of logistics that healthcare has not had to deal with this quickly. But the article that sort of got me into operations side of healthcare, the diffusion of innovation in healthcare, which talks about how, you know, it took 256 years to cure scurvy. It's a great piece to read that, you know, we did what took 250 years to diffuse citric acid across the British Navy in 11 months. And now comes that last mile. And this is where it gets really interesting. And it's not going to get closed except for leveraging digital tools.
Yeah, and it sounds like we're all fans of the history of science, the history of medicine here, which is wonderful. You know, I think and hopefully you've read a lot of the 36 books that Everett Rogers has written around the diffusion of innovations, and particularly the book titled The Diffusion of Innovations. If anyone in the audience has not read that book, I would highly recommend it. It was one of the cornerstone works in my dissertation, my work, but it is, and it, you know, Malcolm Gladwell used a lot of that work in his books as well. But it is it is really an important work, again, written in '64, in studying using trace methodology, the rise and the diffusion of nuclear power and the polio vaccine. So again, we get back to vaccines, and I think you know, these sorts of things are just incredible. Let's keep on that point though. This is really interesting, and Dr. Jensen, maybe you can talk a little bit more about it as well. But you know, from the perspective and the point of view of a cancer hospital, what are you thinking about? How are you looking at the vaccination effect with cancer patients and the digital tools needed to surveil and understand whether it's from a patient repository or some sort of record keeping purpose? How are digital tools going to be utilized by by your staff. Again, you're chief digital officer of one of the best cancer hospitals in the world. You know, in the middle of a city, urban, you've got a mixed population, urban, suburban, rural. You've got remote patients coming from around the world. But what are you guys looking at in terms of monitoring how this vaccine affects cancer patients?
There's, I guess, 4 dimensions to that. So unfortunately, I'm going to have to go through all 4 because it's the only way I can answer your question, but I'll do it quickly. So the first one is patient-reported outcomes. We've had that for a long, long time. And in some ways, we've underestimated because we never had the computer analytics tools to combine patient-reported outcomes meaningfully with the phenotypical data that says this is what actually happened. Well, it turns out now we can. And here's a tidbit for you, which is pre-COVID, got nothing to do with COVID. But we ran a trial that said people that report their outcomes every day versus people that don't report their outcomes. And they were cancer patients that were comparable cohorts. The patients that reported outcomes every day lived on average 5 months longer than the ones that didn't. 5 months. For a stage 3 and stage 4 patient, that's a lot. That's more than many, experimental drugs will give you, just by reporting the outcome. It had an effect on how we were able to closely monitor, adjust the care paradigm, but there's probably something going on in your head as well. There is a connection between mind and body. We don't quite understand it, but we do know that 5 months was the outcome. So that's the first part. The second part is where we went. It's all the monitoring devices, etc. I mean, that's a well understood problem. But there's a logistical component where you went like 10 minutes ago, clinical trials. Okay. How do you actually handle the monitoring on clinical trial? Because that has a lot of monitoring. When you can't ask people to come to your facility. We're now doing clinical trials with oral drugs 100% virtually. We can ship you the drugs. That was logistics we had to stand up. It was arrangements we made with the pharmaceutical companies. You get the drug shipped to you. We try to monitor. We have follow-ups, etc. So there's a whole set of logistics around clinical trials. And then the 4th dimension is there's also a research dimension. It says we need to not just take care of patients, but we're living in this different environment, virtual care, the pandemic's still going on. You need to also learn from it. And how do you collect all the data in a meaningful fashion and turn that into a digital model that can hopefully accelerate new generations of research that will teach us not just about cancer, but about the interaction between not so well understood viruses and cancer. This will not be the last coronavirus we have to deal with. I can guarantee you that. There will be others. And the more we learn from this incident to good data collection and rapid research, the better prepared we'll be next time. So that's the 4th dimension.
Yeah, I think that's really a brilliant observation. It's just the lessons learned on this. And yeah, I mean, when you talk about measuring outcomes, what Sloan has done over the last 50 years, and I remember when I was in grad school doing case studies on the outcomes group that was being formed and working with a lot of the new health IT tools in the 80s. It was incredible to see just how far ahead of the curve and how much investment Sloan put into health data outcomes and a lot of the kind of early outcomes IT companies that were just aggregating data, analyzing it, visualizing it, et cetera. They were, Sloan was buying all those software and implementing them and understanding the outcomes. And obviously, today looking at the best practices coming out of there, it's critical. And now understanding how all that's going to be affected by this vaccine and how that's going to continue on will be critical. And so Vinod, the question now coming in from someone is around pharmacists and the virtualization of care. And I think we've not talked a lot about that, and I think certainly when we look at who patients have interactions with the most, it's the pharmacist. And so the question is really around: do you see clinical pharmacists playing a role in providing virtual care to help physicians with monitoring patients on complex medication regimens or managing the side effects of those medications for conditions such as multiple sclerosis and cancer and so many other complex diseases? What's your how do you see the virtualization of care tools right now and all the different dozens of institutions that you have contact with affecting that paradigm?
Sure.
So I can talk about certain situations where we have implemented this kind of project around virtual care. So what we call is basically care pathway, where we are monitoring these patients using technology and algorithm and data and all those kind of things. And on caregiver side, we are helping these providers to form a team that will basically use this technology platform to monitor these patients. Now, this particular team, is care pathway team is what we call them. And one of the key role we have, or key, individual we have there is pharmacist there, right? Because whole idea is basically to have, this technology monitor patient, collect the data from devices and other things, and continuously, as I said, track the trajectory for that particular patient. On caregiver side, it is, a whole goal is basically for low and medium risk patient. How do you kind of, use this technology platform to monitor the patient? And then other part, which is, keeping specialists busy with, very, very complex patients rather than looking after these low risk patients. So there, instead of, using, specialist time, what we are doing is basically we are using team of RNs and pharmacists to monitor this patient using algorithm and data and platform and other things, right? So there, pharmacist becomes one of the key team member that is monitoring these patients, and algorithm is basically pushing out observations and certain recommendations, and then pharmacist is basically reviewing those details and assigning certain tasks to either RNs, communicating with physician, communicating with specialist through the systems, and then that's how this entire care team is kind of providing care for the patient. So pharmacist is becoming more core part of this remote patient monitoring as well as care advisory for this patient using devices and other elements.
Yeah, that's absolutely spot on. And that kind of care coordination model, medication therapy management, there have been a number of different frameworks in which that kind of pharmacist-physician relationship has been bolstered. And Dr. Testa, how do you see the system at NYU? Again, very complex health system, medical center. What do you see, and how are pharmacists today involved in that value chain, and where do you see that changing perhaps tomorrow with the distribution of the vaccine, and then the need to set up and understand from a patient data registry standpoint how that is affecting your patients on an ongoing 1, 2, 3, 4, 5 year basis?
It sort of gets back to my comment about there's no two ways about that. We cannot design this to all be funneled through the provider. This virtual health is team-based by nature, and for that reason, our pharmacists, our clinical pharmacists, were they're the ones that quickly came to us to say, hey, by the way, remember, we really need video visits. Going back to telehealth 1.0, we can do things that with rapidly to expedite discharging of patients. We can engage with them as soon as they get home, rather than as they're heading out the door, or to longitudinally track these folks and intermittently engage with them to understand their medications, and to do that medical reconciliation, which is frankly not incredibly valued among some clinicians, and is of paramount importance. So I think there's no way to get through what we have ahead of us without intimately involving our pharmaceutical professionals, the clinical pharmacologists, pharmacists, in how we engage with these patients outside our four walls.
And so one of the studies that I led about 10 years ago now was with McKesson as a sponsor. We were doing our rapid testing that we do. It was like a 30-day study, and we engaged with a medical group. It was a large, if you know Westchester at all, they were in Austin. It was a large single tax ID medical group. And we tied the care coordinator, the primary care doc, and the pharmacist all together on one system. And it was a test to see how the improved communications could actually affect outcomes for type 2 diabetes patients age 25 to 45. And so what we found is that the outcomes were far better than we had hypothesized. So A1C levels, blood sugar levels, overall SF36 levels all improved. And so there is evidence, again, you know, not that this is surprising, that improved communication amongst those three, you know, especially if you throw in, like, one of the earlier questions was around the lay caregivers at home for especially the older adults, that, you know, this is something that could be a kind of a major differentiating effect. Is this what you're seeing as well, Dr. Jensen, with cancer patients? Has MSK created a model, a framework where there's improved communication between the patient, the pharmacist, and the physician, especially the specialist?
We have, and it's part of our integrated care model, which we have now transcended into this virtual care model. So we've seen the same as Dr. Testa talked about. We literally have video consults with the pharmacists. I talked a little bit about the fact that it's a multidisciplinary team. It's not actually not just the pharmacists, it's everybody that's on that care team that can connect virtually. Somebody asked your questions, I'll just clarify that it was 5 months longer, by the way, in terms of that trial we had. But where I want to go with it is, you can take that model and you can extend the thought to be cross-provider institution. Because we've always had barriers where referrals are like this thing where you go, you get your journal and then you get a pile of paper, and then you go with your CD or your pile of paper and you go to the next provider institution. And then we say, well, no, the EMRs are going to solve that because we're now going to do record exchange. Yeah, it doesn't quite work that way, because all the health systems have slightly differently configured EMRs and it doesn't quite transfer. You can do the basic stuff, it still gets hard. And what about the images? So we don't have a physical connection problem. We have a semantic and understanding problem. But even when we fix that, we still have the problem of integrated science. That's different from integrated data. I can do integrated data all day long. Right? If you can get me the connectivity and the semantic mapping of the data, I can do integrated data all day long. But integrated science is harder because every single provider institution has different specialties. That's why they exist. There are different things that are particularly good at. How do you create integrated science across time and space? We have to solve that for our 20-odd sites, because you can't just shuttle people around when you're in the middle of a pandemic and New York City's closed down. So how do we organize the 20 different sites that MSK has? I actually personally think, and we think, that model is transferable to cross-institution. And ask yourself this question: what if part of virtual care also was virtualized diagnostics? So we can actually start doing integrated science, diagnostic science, with the different specialties sitting in different provider institutions. Wouldn't that be a wonderful way of doing more good for the world?
Yeah, I think that's absolutely well stated, and that would be wonderful. And I think that's where we're trying to get to. And certainly one of the interesting tools, I don't know if you've seen this, any of the three of you, but there's a foundation out of Utah that was founded by a myeloma patient. Actually, she's an MSK patient and a BYU grad, 89, but a mother of 5. Her husband's a venture capitalist in Silicon Valley, goes between Salt Lake and San Francisco all the time. But she ended up being diagnosed with myeloma. Actually, was treated at MSK. And out of that, she, you talk about that barrier, and that's absolutely right. What's the blockage that we're talking about there? And data, as we've heard all week long at this summit, it is critical that data has no friction, that data can transfer between physician, between patient, between pharmacists and nurse and caregivers absolutely seamlessly, but within HIPAA guidelines, within absolutely private and secured pipelines. And CrowdCare is, they actually have put together a personal health record for cancer patients to be able to share, well, specifically myeloma patients. They have several thousand of them now, and it's all about that, sharing that data. So it's a mix of a personal health record and a patient repository or a patient registry mixed all together with a functional user front end that's absolutely gorgeous. That like Lee and Glenn just talked about in the last hour from Livongo, they talked about having it be so good it's like Google. You just want to go on and start searching, or Amazon, you want to go on and find your next book. And so that's a incredible story from a cancer survivor who actually went out and started a PHR went around and gathered up a lot of that data to coordinate care from the patient standpoint. And I think MSK is actually using that PHR now, or doing something with CrowdCare and Jenny. So Vinod, we've got about 5 minutes left. Bring us home and tell us more about what you're seeing across all the different hospital systems and all the different health systems, pharmaceutical companies that Persistent is supporting today, and where you see the future of the digital front door, of the virtualization of care, whether it's a large multi-center academic medical center or a highly specialized global cancer leader. Where is the future of all this going?
Yeah, so broadly speaking, we are looking at like 3 different across, if I have to generalize, then across all these health systems and pharma and peers, broadly speaking, there are 3 areas where, there is a lot of effort and discussions and, momentum is going on. The first part is more on patient engagement and patient experience part, where, as you said, like, it is going to be patient-driven care rather than health system-driven care, and it is going to be on-demand care. And then we are seeing that all these companies, across healthcare ecosystem, are trying to kind of get themselves ready, to extend their existing systems and establish this digital channel, for that experience and engagement. And that's where we are helping, some of these health systems and providers, peers, and pharma companies across the board to help them do that. That is the first part. The second part is, and I think this is going to get accelerated multi-fold, because expectation from patient is also like just the way I use other services, other industry services, just like that I'm going to use healthcare, and it's going to kind of create very interesting situation for health systems as well as the healthcare ecosystem player. The second part is more on clinical side, where this was the topic of this discussion, so I'll not repeat whatever we already said, but the extension to that is telehealth, telemedicine 3.0, where we are going to leverage data, we are going to leverage devices, algorithms, and other digital technology to monitor patient, provide care where patient is at. And then I think this is going to go further and further. We are working with some of the health systems to also run genomics pipelines and other elements to kind of be more predictive and proactive, and provide personalized care for these patients. And this is going to grow in my mind. The third component, we are helping these health systems and healthcare ecosystem players is on using digital technology as weapon to make their operations more efficient across the board. And there also we are seeing great traction and great momentum from these health systems and healthcare ecosystem to leverage this technology to their advantage. So I think all in all, if I have to summarize, this is right time, and then the entire ecosystem is kind of helping. And if I think COVID is pushing us in this direction, and I think earlier most of these players were looking at problem, but now they are transferring their focus more to solution rather than focusing on problem, and it's like a positive sign, Stan, from my perspective.
No, that's brilliant. Thank you, Vinod, and really great framework. Thank you for kind of concluding the hour with this tremendous panel with a great framework to look at how the future of this is going to come together and what the future of virtualization looks like for the U.S. healthcare system. Again, thank you to the 3 of you for taking out an hour on an extraordinary busy time. I think there's again like 10 business days left in the year or something. It's we're winding down 2020 pretty quickly here. But again, thank you, Dr. Testa, Dr. Jensen, and certainly Vinod Parale from Persistent, and have a great rest of 2020, a great holiday, and we'll see you in the new year.
Thank you.
Thank you.
Thanks so much.